Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Vagaseltzer.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi everyone, thank you for joining me on tonight's Egg Whisperer show. The title of tonight's show is The Truth About Fertility Drugs. So I'm going to pause and sing a salt and pepper song right now. Let's talk about drugs, baby. Let's talk about BCP. Let's talk about all the good things and the bad things that may be. Oh, that did not sound very good. Let's talk about drugs. So that's what tonight's show is going to be about. I love salt and pepper. Salt and pepper, you need me to be your opening act. I'll talk about sex. That's what I do anyways all day long. So on to more serious business. For those of you who are joining tonight's show and you're like, who is that? I don't know that I want to watch this because she just sang and that was atrocious. That's okay. I'm actually a fertility doctor. You can trust me. So my name is Dr. Amy and I've been practicing in the San Francisco Bay Area for over 10 years now. So there's this Facebook trend of people posting, 10 years before and after photos, and I basically have been doing the exact same thing, trying to help people get pregnant every single day, one uterus at a time. So with the experience that I've basically gathered and in treating so many patients on all different kinds of medications, you can imagine there isn't a side effect that I haven't seen before. So with this in mind, I thought tonight's show would be a great opportunity to talk about different drugs. And hopefully you'll learn from my tips and tricks that I give my patients, and hopefully that will help you no matter where you live and no matter where you're doing treatment right now. So what I did to prepare for tonight's show, I just took a whole bunch of calendars that I've made for patients recently, and I thought it would be a great opportunity to just bring them up and talk about them. So let's talk about this one drug. It's so weird. Birth control pills. So a patient called me and she said my period started. She's coming from out of town. She knows she's going to be here for just 2 weeks. So what do we do in fertility medicine? In some cases, we put patients on birth control pills. And it's like, wow, why would you do that? Because don't you want to get pregnant? Well, we think about birth control pills also as IVF readiness pills. And they work great. They basically pause your ovulation and they shift things. So it's kind of like your cycle day one, cycle day one for the entire time. And the rules of birth control pills are basically, in my book, I don't like patients to be on them a super long time. And the reason is because they can suppress the ovaries and make it harder for the ovaries to wake up. So if I have a patient that needs to come at a certain time and I need her to be on longer than 10 days of birth control pills, for example, I might start and stop them. And what that means is this. A lot of people get scared and they call me at 2 a.m. No, they don't, because I educate them about what not to call me about at 2 a.m. But in all seriousness, after you take your last birth control pill, it's super normal to have a period, and it's also super annoying. So that's one of the things about birth control pills that sometimes people forget. We use them as IVF readiness pills. We definitely want you to get pregnant, and it's also normal to have something called BTB, also known as breakthrough bleeding. Why? Well, it takes your body maybe 2 to 3 months to adjust to a birth control pill. So when you're taking it for the first time and just for a short period of time, it is very normal to have a super annoying brownish discharge. Sometimes it's red, sometimes it's brown, and then it's also super annoying to have another period again, basically 10 days after you just had a period. So as long as you know what to prepare for, you won't be surprised, you won't be upset, because I told you it's totally normal and totally okay. And the other problem, though, with birth control pills, what you should know about is one thing to definitely let your doctor know about, and this is what I tell my patients, is if you have a severe headache, let me know. Birth control pills can sometimes cause headaches, and if you're prone to migraines, you may not want to take birth control pills because it can make your migraines worse. If you don't have blood pressure that's under good control, you want to avoid birth control pills as well. So talk to your doctor, make sure that this is the right protocol for you, and always ask more questions. And if there's a symptom that you're just not sure about, again, ask more questions. Let your doctor or your nurse coordinator know. In my clinic, patients ask me, who's your nurse coordinator? And I say, me. Hi, nurse coordinator. I'm here to help you because I know everything about you, everything about your care. Certainly, I have an awesome team. We call that team the dream team. But at the end of the day, because I spend so much time with my patients talking to them about their stories and the protocols that they've been on before, I certainly like to ask their medical questions and design their calendars for them. So on to the next page of this patient's calendar, what you'll see is that she's going to be undergoing some monitoring ultrasounds, and she'll be taking a shot every single night for 10 nights. And I know some of you are like, shot? I didn't know I needed to take shots during this process. Yes, you take shots, not shots of tequila, although that would be yummier and way more fun. Yes, it would be, than a shot in the skin of your tummy. But there are a number of different medications. There are several different drug companies that basically make medications called gonadotropins that make the ovaries and the follicles grow. Here's some things that you should know. These shots cannot create more eggs than you already have for the most part. If you start off with 5, you're for the most part going to end up with 5. And sometimes when you try and grow 5, you might get 2. So ask your doctor, how many follicles am I growing? How many mature eggs do you expect? What do you think about the cycle at every single visit? This is what I share with my patients because I want them to feel super informed, because at the end of the day, a lot of this is out of our control, right? It's like sitting in traffic and you have no control over the cars around you. So you got to figure out a way to make it as enjoyable as possible. So one of the ways to make it as enjoyable as possible is to come and do treatment with me. Because you'll always laugh because I sing to my patients most of the time when they're asleep, because that's when I sound really, really good. So I want to move on to another calendar. This is a medication table that I give patients for their embryo transfer, whether you're doing a fresh embryo transfer or a frozen embryo transfer. So let's go through these medications, and I'll talk to you about some of my tips and tricks. So the first thing is Estrace, also known as estradiol, and I hear patients call it Estrace, and that sounds very elegant, but actually the right way of saying it, or the correct way of saying it, is Estrace. They come in these blue little pills. Typically I tell patients to take 2 tablets in the morning, 8 a.m., 2 tablets at 8 p.m. 8 a.m., 8 p.m., easy to remember, okay? Your prenatal and aspirin, not time sensitive. And here's a little trick. If you get your aspirin prescribed at the pharmacy, the tablets are smaller than what you can get over the counter. As far as PNV, on my med table, that stands for prenatal vitamins, and there are a number of different prenatal vitamins out there. I have my recommended brand, but certainly ask your doctor the brand that they recommend the most. Ideally, you want to take a prenatal that you'll be able to tolerate well without feeling sick to your stomach and super, super gross. So moving on from the Estrace, actually, before I do that, there's one little thing that I have to tell you about, and that's called smurfgina. Okay, you're probably wondering, like, what the heck is she talking about? And I think I might own smurfgina.com and maybe pharmgina.com. I think I might. I have to check on GoDaddy. But basically, when I have patients that take the Estrace, one of the side effects that they might have is breast tenderness, also maybe a dull headache, and egg white cervical mucus, because that's how your body reacts to higher estrogen levels. But sometimes people can't tolerate it and they just feel more emotional than they want to. So what I tell them is, look, you can stick the estrogen in your vagina. And they're like, what? I can just hear the messages as they're typing across their screen or their phone, like, seriously, you just told me to stick estrogen in my vagina? And I said, yes, actually you can do that. It's not harmful, it's not bad. Just realize that your discharge is going to look very blue. And if you are having sex, don't worry, your partner's whatever is going to come out possibly looking blue, and that's okay too. Tell them not to be scared, okay? So don't be scared. It's okay. So moving on, that was kind of awkward. And I do have these conversations in my office, and they're kind of fun. Okay, so moving on, we have the progesterone shot. Okay, so I prefer progesterone ethyl oleate because I find that it's easier for patients and they can tolerate it better. So here are some of my tips and tricks. Tip 1, ice the area first. Make sure you're going high enough. If you go too low, you'll get a skin reaction. If you go too medial, you're going to hit your sciatic nerve, and ouch, you might have a hard time walking tomorrow. I tell patients to draw it up. They can warm it up in their fingers, put it under their boobs, in between their boobs, sit on it for a few minutes, and then do the injection. After the injection, hire a butt massager. If you don't have a cabana boy, find one. Use a heating pad and rub that area. You can also use one of these like handheld massagers that vibrate and put it on your butt. But if you have a partner, tell them not to get any sexy ideas, and tell them not to slap your butt either, because after that progesterone shot, getting your butt slapped, everyone in my studio right now is laughing. They can't control themselves. But it's really mean to slap a woman's butt who's taking progesterone shots. I'm just telling you, not funny, so don't do it, okay? This shot lasts for 10 weeks. 10 weeks. The reason why do progesterone shots have to last for 10 weeks is because the placenta takes over by 7, mostly 9 weeks of pregnancy. So that range of 7 to 9 weeks, we like to go over to 10 weeks just to be 100% sure the placenta is going to be able to do what it needs to do to support a pregnancy. Progesterone, promote gestation for pregnancy. It's good. There's no such thing as too much. The reaction that you need to tell your doctor about: severe redness, going down your leg, a rash, bad itchiness. So if you have any of those symptoms, call your doctor, tell them immediately. There are creams. I ask patients to use a Benadryl cream or an anti-itch type of lotion that you can rub over the area. And certainly not everyone reacts the way that I would want them to the ethyl oleate, and sometimes I switch them to sesame seed oil. Or we switch to the endometrin, which are applicator-loaded tablets that get placed in the vagina, and that's where vagaseltzer comes in, and we'll talk about that in a little bit. Okay, so doxycycline is an antibiotic. We just automatically put patients on it. Is it required? The answer is no. The risk of infection from an IVF procedure like a frozen embryo transfer is like 0.001%. I've never had a patient get an infection, but we're just so used to doing the same thing for everyone, so most fertility doctors still put patients on antibiotics. So skip it if it makes you nauseous, you've had bad reflux, esophagitis, or if you're prone to yeast infections. Trust me, the last thing you want to do is go into your frozen embryo transfer or your embryo transfer procedure feeling really itchy, uncomfortable, with burning. No, you don't want to do that. And if that happens, call your doctor immediately, and I prescribe my patients diflucan or tell them to go get Monistat or something similar over the counter. Moving on, we have Medrol right here. So most fertility physicians, not all, use a steroid to decrease inflammation in the body. Medrol is also known as methylprednisolone. So this drug, about 1 in 40 patients or so, will wake up the next morning after their first tablet with a big, fat, red face. We call that facial flushing. Is that a normal reaction? It can be. Do you need to continue the medication if that happens? No. So I tell my patients, if you wake up in the morning and you're like, oh, I feel like I'm in an oven right now, please stop the Medrol. It's not going to help us. There's no need to be doing that, okay? The other thing you should know is that Medrol is disgusting. It tastes totally gross. So put it in a scoop of ice cream, a little bit of yogurt, plug your nose, and then swallow it. I prescribe 16 milligram tablets. Sometimes the pharmacy doesn't have 16, so we order 4 milligram tablets. The way we do that is through something called a Medrol dose pack. So these are some little tips. If you get to the pharmacy and they're like, oh, we don't have the medication, we won't get it for 4 days, just say, Dr. Amy said you can use a Medrol dose pack. Bam, there you go. Problem solved. Okay, let's talk about another med table here. So this is something very similar in that I'm trying to prepare a patient's uterus for a transfer, trying to get her lining super juicy for a juicy embryo so that we can see that little spark of life going in through that catheter as the embryo is landing in the uterus. So this is another way of doing things. I really like the Vival patch. This is an estrogen patch. Remember, you can take estrogen pills orally, vaginally. You can use a patch or even put it in your butt in a shot. The patch is wonderful in that a lot of patients have less side effects, less headaches. The only problem sometimes people report is like just a skin reaction from the patch. And before I realized that there are adhesive, they're like alcohol swabs, but they're adhesive removal swabs. You can get them from Amazon, super easy. You take 2 patches, put it on, 2 days later, take them off, put 2 more on, and then I slowly go up over time to 3, maybe even 4 patches for a gold lining of 9 to 12 millimeters, okay? So be sure to get your adhesive removal pads to make using the Vival patches super easy, so you're not, you know when you use a Band-Aid for a really long time and you see that grayish tape around the area, or the grayish like gluey sticky stuff, you're not constantly like picking at your skin, because that's really, really annoying. So the other thing is, on this calendar, this patient is using a medication called endometrin. And I just think about it as like literally Alka-Seltzer, but Vagaseltzer. So you take the tablet, load it in the applicator, and you have to place it 8 a.m., 2 p.m., 8 p.m. That's what I tell my patients. And I literally tell my patients, if you skip one, you're done. Like, it's awful. So don't do that. I know that sounds really scary, and I try and scare people, because what people say to me is, Amy, which one's better, the vaginal inserts or the progesterone shots? And I say, if you ever skip one insert, you're fired. You have to do the shots. Like, you don't get a second chance, because you don't get a second chance to like forget a progesterone. You just can't do that. And so my patients have alerts on their phones. They set them for 8, 2, and 8. My patients do great on the inserts, but some people don't have the time, especially teachers, for example, to leave a classroom and go place an insert and then come back to the classroom. So think about what will work for you. And one of the reasons why I like to do a mock embryo transfer or rehearsal cycle before the actual thing is it's so that we kind of learn what your body will react well to. So if you don't like the endometrium and it gives you an awful yeast infection, you then have the option to use the progesterone shots for the real thing. And then you won't have to be all uncomfortable and have to deal with a yeast vaginitis or something like that. Okay, so moving on to another calendar. So this is another type of frozen embryo transfer calendar. So this is, so I kind of showed you the part when you start progesterone, and now I'm going to show you the part where you're preparing for the actual transfer, and there are a number of different ways of doing that. So you can still start with birth control pills, and that is to prevent ovulation. And this is also so that you can use other medications like Lupron. So think of birth control pills as your belt and Lupron like your suspenders. So you don't want your pants to fall off. Are you following me? So your pants falling off is like ovulation. So you take birth control pills to prevent ovulation, and to just really make sure you won't ovulate, you take a small shot of Lupron in the skin of your tummy. So when you Google Lupron, don't freak out, because a lot of people freak out. They're like, you want to give me what? Because the horror stories are literally that, horror stories of people taking a drug called Depo-Lupron that puts you into menopause, the subcutaneous Lupron. The side effects that I stop it for are some patients actually feel really emotional. I've seen elevated blood pressure in some patients with it and some patients with headaches, but for the most part, most patients tolerate it pretty well. The other medication that I use in my frozen embryo transfer protocols that I think can help, especially in patients who have an elevated histologic score of BCL6, is something called Femara, also known as letrozole, and we'll talk about that in a little bit. But this medication I use for 5 days at the beginning of the cycle when patients start their Estrace or their Vivel or their estrogen tablets, okay? So I always put a smiley face next to the transfer date and a smiley face next to the pregnancy test, because certainly I look forward to every opportunity to help people, understanding that we go in with a realistic set of expectations, and if something doesn't work, we always look back and say, we did our very, very best, because we talked through everything. We understood what we were doing, how we were doing it, and we felt really, really well prepared. Okay, so now I want to get to some IVF calendars and talk about the drugs there. So that is you, the name is you, so that's your calendar. And here, this patient, this is what I call a hybrid IVF calendar or a mini IVF calendar. So this is a combination of fertility pills overlapping with injections. You can also use this approach for IUI. For those of you who don't know what IUI is, thinking of it as the turkey baster. And I swear I have a patient who nicknamed me her turkey baster. Literally, she's like, you're my turkey baster. I thought it was actually pretty funny, and it was around Thanksgiving, so I thought that was pretty clever. So now when I walk in to do a patient's IUI, I say, hi, I'm your turkey baster. No, but it is funny to think about it that way. So anyways, talking about the drugs, so what I put patients on is a combination of Femara, also known as letrozole, and Menopur. Menopur is also known in my office as Menopur. It's very French, it's very fancy, and it's very expensive. And so Menopur is a combination of FSH and LH, and these drugs can also help get your follicles to grow, and the goal is to maximize the potential number of mature eggs that we can get in the safest way possible for patients. So going down the list, you see the medications Cetrotide. Menopur dilutes immediately. The powder, once you dilute it, turns clear. When you dilute the Cetrotide, it gets a little cloudy, and I tell my patients they can line all their vials up. Ask your doctor. This is my approach. The advice you're getting on this show is the advice that I give to my patients. And for you guys out there who aren't my patients, this is just for informational purposes only, and hopefully there's a slight entertainment factor as I try and make a fool out of myself tonight especially. So going down the list, we have the Cetrotide, and my patients report that sometimes they get an injection site reaction. I see that more commonly. I would say about 1 in 4 patients will get an injection site reaction. Just the skin gets a little bit red. It looks like a quarter size, and maybe in about 15-20 minutes it goes away. Sometimes it goes away the next morning. Very rarely it's a larger size, but typically having a Benadryl or Benadryl cream on hand can help with that if it's very uncomfortable and very, very itchy. Another medication I give my patients is HGH. When I say that, the men in the room sometimes get really excited, like, oh my God, can I have some? And I'm like, sure. No. But HGH is a drug that may improve egg quality. I also use it in a priming fashion where I give it to patients 2 to 6 weeks almost before their IVF cycle to get the eggs ready and give us the best chance of having as many eggs at the highest quality level possible. So moving on to my next calendar, Moving on. Here we go. This is what I call a Menopur only or standard IVF cycle using only injectables from the beginning of the cycle. The decision I make as far as which protocol to use is based on the number of follicles I see, the patient's age, her antral follicle count, and what our goals are. Everyone's goals are different. Everyone's plan is individualized, but you can mix Menopur, for example, with other drugs like Gonal F or Follistim, and these medications can also, like I said, get the eggs to grow. But what you'll realize is as you're taking the medications, you start to feel swollen. Some people report feeling like a potato, and I would say a very fertile potato. And then you'll also notice maybe some breast tenderness, some slight headaches, and then sometimes patients feel nauseous. So I like to manage symptoms of my patients, so I prescribe an anti-nausea medication like Zofran, and I let them know that it can also cause constipation. And I also like to tell my patients that around, I would say treatment day 5 to 7, they might start to notice some egg white cervical mucus, and sometimes it reminds patients that they might be ovulating, and I tell patients that sure, when you're ovulating, your estrogen levels are higher than normal, and that's why you see the egg white cervical mucus, but it's not because you're going to ovulate, because that's what the Cetrotide is for. Cetrotide will prevent ovulation, and there's another drug called Ganirelix that works in the same way, and both medications, like Lupron, you can take that starting a week before you start your cycle to also prevent ovulation, or in a microdose fashion, starting around when your period starts to also prevent ovulation. So we do these medications in advance to prevent ovulation, because you can imagine that going into an egg retrieval and not getting any eggs because the follicles have collapsed is kind of a pisser. It sucks, let me tell you. So, I would say that with the patient population that I take care of, maybe once every 2 years, this will happen. And I wish I could say that it's preventable, but you just learn from it and then you see what you can do differently next time. So talk to your doctor about the protocol, why they're using that protocol, what the side effects are that you should be looking out for, and always have an emergency number so you can call whoever you need to call if something just doesn't seem right and you're really, really worried. Between 7 and 9 p.m. is when I tell my patients, oh my gosh, that's my cell phone, I should take it off. Now everyone has my cell phone number, so I FaceTime and Skype with my patients between 7 and 9. Here, I'm going to do that. Don't call me tonight, people. Just kidding. Please don't call me. Okay, so moving on. This is another protocol that I put patients on, and some patients I put them on Lovenox. So Lovenox is a drug that can, in certain situations, and again, talk to your doctor about whether it's right for you. Just because you see it on this med table doesn't mean that it's right for every patient. Lovenox in some cases can improve implantation in the right situation. And so what I tell patients to do in this case is before they give themselves the shot, rather than squeezing the skin, stretch it, make sure that there's no blood vessel in the area, place the needle, and then go very, very slow. It comes in a pre-filled syringe, so you don't want to go super, super fast. And as you come out with the needle, you don't want to rub, because if you rub, you're going to get a big fat bruise, and then your belly is going to look like someone just sat there and beat you up, and that's not really that cool. And not that my patients are doing any bikini contests or anything like that, but just having bruises all over your tummy is just not cool. Okay. So I am just about done with tonight's show. So what better way to close it off than the Tushy method? And ever since I started this campaign, ever since I started this campaign in May of 2018, I can tell you that so many patients who've come to me as new patients come in well prepared. They come to me with all the puzzle pieces. They know that I want their Tushy checked. They come in with their Tushy prepared, their Tushy is tucked, the puzzle pieces are there, the reports are there, they have their Trapper Keeper binder, and they're showing me their pictures and their uterus image and their sperm analysis and their hormone levels and their genetic tests. And if someone doesn't, if someone just has the tush and not the E, or the ushy and not the T, well, I can definitely fill in the blanks. You get my point. Not everyone needs every step, but certainly at least having your hormones checked, maybe a semen analysis. Those are good things to start off with when you go to the fertility doctor, especially if you're over a certain age. Having that AMH level done ahead of time is a really good starting point so that your fertility doctor can start the conversation about what's the best treatment for you and why, and the right protocol. So in my style is that if I have a patient who comes in who's 32 years old or older and does not have one child already, I always talk to them about fertility preservation. For example, freezing eggs, or if they're partnered, freezing embryos, so that you can never look back and say that you didn't take your, that you tapped into your young fertile eggs and didn't take your youth for granted, until the day that we have an invention where we can actually inject some youth serum or Botox in your ovaries, which we still can't do. One day we will be able to, and one day we'll be able to do a male uterine transplant. I think we will, but I digress. That's a show topic for another day. But until that day, the best thing that you can do is preserve your fertility, take advantage of your youth, and see a fertility doctor that believes in you and has a positive mental attitude. And there's so many of us out there. So we'll just go through the elements of the T. I should have a cheer, a U, a S, an H, and a Y. So thank you guys for watching tonight. The show's topic, if you're just laughing at my jokes and not knowing what I was talking about, was the truth about fertility drugs. And the last thing I'll close with is one of the most important questions that I address with my patients, and it's one of the questions I ask in my history taking, and that's about family history of cancers like colon, breast, and ovarian, as well as uterine. And the reason is that fertility treatment is really common. Cancers like breast cancer are very common, and I want all my patients to live as healthy a life as possible and live as long as possible. So I talk to them about doing an inherited cancer screen and address their concerns about cancer. And if someone's at high risk, there's certain medications that we can use throughout the cycle, like Femara, that can help. So I hope you guys enjoyed tonight's show. And if you have a fertility question or if there's a show topic you want me to do in the future, please feel free to email me, email@eggwhisperer.com. Subscribe to the YouTube channel, subscribe to my Medium account. And, if you need to catch a previous show and you're like, wait, I want to listen to that again, you can always go to my podcast on iTunes. Thank you guys for watching and have a great night.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Vagaseltzer.
And you have yet another success story.
Just launched by an East Bay fertility doctor.